Right. Morning, everybody. I think we've sorted the tech issues, but it remains to be seen because somebody who's at home. Right, Paul, sound is good. Is that correct? Teams. Yeah, lovely. Thank you very much for coming, and thank you to Mr. Sam Jeffrey, who was today about decision making in emergency neurosurgery. I could say something rude here, but maybe I'll save it for after your talk.
Please do.
To not make you feel like you're in too much of a hostile place. And yeah, so we'll have some questions at the teams. Thanks very much.
Okay, thanks. So, I mean, this talk was originally designed for the Head Start course, so for people just starting their neuroanesthesia block. But I appreciate there's a mix of people here today, so you are very seasoned neuroanesthetists who probably see more neurosurgery than me, and others will sort of have a fleeting interaction with us during the on-calls. But hopefully you can give a bit of insight into what we do and some of the decision making, but also give an opportunity to ask any questions, and hopefully I'll be able to enlighten you with some things. So briefly, what I'm just going to cover is really what we do, how we do it, and why we do it, and concentrate mostly on the why, I suppose. Okay, so obviously cranial trauma is a big part of what we do, and you can see these two scans here, both of subdural hematomas, and they look pretty similar, other than the fact that on the left you've got an acute subdural, and on the right you've got a chronic subdural. But you know, there's a similar degree of midline shift and mass effect. But obviously, most of you will realise that the patient on the left is likely to be deeply unconscious, possibly with a blown pupil following a high speed or high velocity impact, whereas the patient on the right may well be sitting up in bed having a cup of tea, chatting to you. Okay, they're very different patients despite the very similar looking scans, and we manage them very differently. With the acute subdural, blood is initially thick and clotted, a bit like blackberry jam, and the only way to get that out is with a big hole, so a big craniotomy. So these patients need a big flat, big trauma craniotomy. They're often very unwell, sometimes have underlying brain injury as well as the acute subdural, and may well go back to the intensive care unit, intubated, ventilated for some time. Whereas the chronic subdural, this blood is now liquefied, and so can be evacuated through a small hole, just one or two burr holes, and these patients wake up pretty quickly, go back to the neurosurgery ward, and usually make a fairly good and quick recovery. The other big pattern of injury we see obviously is diffuse brain injuries. Again, initial scans may not look particularly exciting. This scan just showed a slightly tight brain, a small petechial hemorrhage. But again, this patient is going to be deeply unconscious from the time of injury. And these patients, as you know, are managed initially on the intensive care unit with intracranial pressure monitoring. And this is the new pressure monitor that we're now using here, which is the more traditional Bolt style. And most of these patients can be managed medically with the various tiers of medical management, which you're all familiar with. But when we fail that, we sometimes need to go to surgical management, decompressive craniectomy, which is a big operation with variable outcomes. And for those that might not have seen a decompressive craniectomy, I'll just show you the various stages of that. This is actually one, I think, being done for a malignant MCA infarct. But you know, big skin incision, a big flap, make some burr holes in the bone, multiple burr holes, join them up with a craniotome, remove the bone and open the dura, and you can see a very swollen, angry looking brain. But that has a dramatic effect on intracranial pressure. You see here that when you take the bone off, the pressure drops, but opening the dura has the biggest effect there and brings the pressure right down. So we can talk about decompressive craniectomy in terms of both primary and secondary. So primary occurs at the time of evacuation of a mass lesion, such as an acute subdural. You may be familiar with the rescue ASDH trial that's just been published that didn't really show much difference between those patients that you took the bone out initially and those that you put it back in. Other than those that you put it back in ended up having more operations, but outcomes in the longer term were fairly similar. Secondary decompressive craniectomy, these ones where we failed with medical management of intracranial pressure. And this is certainly more controversial. Evidence was quite conflicting. However, the rescue ICP study gives us some good evidence for the longer term outcomes in these patients. And as you're probably not surprised, the outcomes are still not particularly good. So for every 100 patients operated on, 22 additional survivors, but only 8 of those had what would be considered a good outcome. And you can see from here, this study classified upper severe disability as a good outcome because those patients are independent at home. Other studies would class, a lower severe disability as a good outcome, but those patients require some form of home care. And overall, we can see that decompressive craniectomy does increase the number of survivors, but it also increases the number of those left in vegetative states. Okay. So decision-making around decompressive craniectomy is still difficult, and it's mostly about selecting the right patients, which we don't always get right, and is difficult to predict which patients will do well. Just briefly, some other types of cranial trauma, so depressed skull fractures, other things we might see out of hours. These you can see here what's called a ping pong fracture in a child. These can be treated quite simply just by signal elevator in and lifting that bone out, pops out again. To more complex fractures that require some fairly extensive reconstructions. Another area of sort of controversy in terms of operative management are intracerebral hematomas, which forms a lot of the referrals that we get. In fact, the most common type of referral we get in the emergency service is for intracranial hemorrhage, but very few of them we actually operate on. This is just an example of one that was operated on, and you can see quite a good post-op looking scan. Subarachnoid hemorrhage, again, high proportion of our referrals, and these are generally managed now with the interventionist radiologists undertaking core embolization. Clip very few of them nowadays. But one of the key things to remember about these patients is they can be quite well at presentation, usually with very severe headaches, but often GCS-15 and quite well, but they can develop hydrocephalus and deteriorate quite quickly. It's just an example of a patient deteriorating within the first few hours of admission with hydrocephalus that requires an external ventricular drain. Similarly, other patients can present with acute hydrocephalus for other reasons. What's easy to miss on this scan is a midline lesion here, a colloid cyst causing hydrocephalus. And in order to treat that effectively, we need to put in bilateral external ventricular drains, which may well be converted to a shunt at a later time if the patient doesn't have the surgical removal of that colloid cyst. This is just a demonstration of what a shunt looks like for those that might not have seen one. Oncology rarely causes issues for us out of hours in terms of operations, but occasionally patients do need emergency procedures. Tumours can broadly be defined into extraaxial lesions such as a meningioma or a vestibular schwannoma. These are tumours that arise from outside the brain, or intraaxial lesions, which are tumours arising from within the brain tissue itself, such as a glioblastoma or a metastasis. One thing that can mimic tumours on scans are infections. It can be difficult to tell the difference between an infection or a tumour, but obviously an infection needs more urgent treatment usually, which is sometimes why we might operate on these out of hours to gain diagnosis. And the other things that we'll come across are the whole range of spine problems, which I'm not going to touch on at all today. So just a couple of things about how we do some of these things and why we're different to some of the other specialties that you work with. I think as many of you will have seen, positioning is absolutely vital. If we get this wrong, then it can make an operation incredibly difficult or even impossible to do. So we do spend a lot of time positioning, and you'll see various different types of position from a standard sort of supine held in a Mayfield 3-pin head clamp through to lateral, prone, in rarely sort of sitting position, or Mr. German's favourite, the knee chest. Another thing, my favourite one, which some of you equally enjoy using, is the Allen table, which is a great way to position patients prone. And once you get used to using it, it's really straightforward. The other thing, obviously, we have lots of kits that is different to other specialties. You will have seen image-guided surgery. So this allows us to navigate within the brain, matched to the patient's scan. And we can combine that with intraoperative imaging, which is increasingly becoming used throughout the country. This is an intraoperative MRI scan, but you can have intraoperative CT or C-arms that add additional information during surgery. And combined with image guidance, you can use that to place screws or stereotactic electrodes for DBS. And you can also combine image guidance with ultrasound to get real-time image guidance. We use the operating microscope a lot, which gives us good illumination and magnification. And again, we can combine that with image guidance to give us even heads-up displays of white matter tracks to help tumour resections. And the other things used is fluorescence guided surgery. So patient is given some a drink called 5-ALA prior to surgery, and then this is selectively taken up within the tumour, and then you can see that under fluorescence intraoperatively. We do a little bit of endoscopic surgery, either through the nose or through the ventricle. So this is one of the nicest operations that you can see, which is an endoscopic third ventriculostomy. You get lovely views of the ventricular system down to the floor of the third ventricle. Just make a hole in the floor of the third ventricle, and then as that comes out, you'll be able to see the basilar artery pulsating away nicely there. And that's used as an alternative to shunts in some patients where there's obstructive hydrocephalus. More commonly used in children, though. Okay, so I think you're probably all familiar with that scenario. So talk a little bit about why we do what we do in a little bit more detail. So what are the reasons for operating on patients out of hours or as an emergency? So can be a number of reasons, but firstly, it might be we want to try and reverse any neurological impairment they've got as a result of their pathology, or try and prevent that developing or deteriorating into irreversible impairment or death. Sometimes we operate because it's a time critical problem and we don't have all the facts we need to make the right decision. So sometimes people get operations where in retrospect you think, well, maybe it wasn't the right choice. And sometimes there's expectation, uncertainty, and also feeling that doing something is better than not doing something. And those are all the things that we need to consider when we're making decisions about who we operate on. So emergency neurosurgery is certainly consultant-led, but frequently registrar-delivered. A lot of certainly cranial emergency neurosurgery can be very safely carried out by registrars of appropriate seniority, and we're very lucky here that we have a very senior group of registrars, and so you may find that consultants aren't visibly present throughout all emergency neurosurgery, but you can be reassured that all decisions are made by consultants with very close oversight. So when I'm thinking about which patients to operate on, these are the three things I think about: the patient, the pathology, and the physiology. So the patient, first of all, what's their age, or probably more importantly, what's their frailty, because that probably has the biggest impact on likely outcome. Their comorbidities, what's their previous level of independence, and what's their rehab potential. That younger, fitter patients are more likely to benefit to have rehab potential and benefit from that, whereas the more elderly and frail are less likely. But equally important is what the patient's wishes, and this is a really key point and often one of the most difficult things to obtain. Few patients will have had explicit discussions with family members about what they would want in certain circumstances, but you can often be guided by a relative's interpretation of what a patient might have wanted, what level of disability they might be willing to live with, and that's really important when making decisions, and we try and get that information as early as possible, and it does frequently change what we do. So the thing about in terms of the pathology or the injury, and that really comes down to the imaging. What's the scan look like? How bad is that scan? And here we're looking really at that difference in primary and secondary brain injury. There's nothing we can do about that primary brain injury. So everything we do from there onwards is about preventing the secondary brain injury from mass effect, brain herniation, ischemia, etc. And how much of what's happened is reversible? So someone with an acute subdural who's got mass effect from that, but no underlying brain injury, has potentially got a very reversible condition. Whereas someone with contusions and diffuse brain injury, as well as their acute subdural, a lot of that isn't reversible. So that may well change the decision, particularly if you're on the border of whether someone's at an age or frailty that you might think a big craniotomy is not ideal. If they've got a completely reversible component, then you might be swayed more towards doing something than if they have an underlying contusion as well. And what the natural history of the pathology? We know that some things get better over time, some things get worse, and there's a period of time in which that occurs. And that may just change the timing of any intervention. And finally, what's the physiology? What's the GCS? The M score being most important. Obviously, patient with a motor score of 1 or 2, bad prognosis. Those with a 5 or 6, much better. Ones in the middle, 3 or 4, more difficult. And it's probably quite difficult for most people to tell an M score of 3 or 4. And so you always have to take that with a pinch of salt. When someone says you've got a motor score of 3, was it 3? Was it 4? It can be quite difficult for most people. It's probably worth reiterating at this point. It's really important to ask people how they obtain the M score. Really, the only way to do it is with supraorbital pressure, because that will help better distinguish between a flexion and a localizing. People who do a sternal rub or a trap squeeze or finger nail bed pressure, it's not a good way of obtaining a motor score. And it's important to get that from the history, particularly when patients are being transferred from outside from the district general hospitals. Pupils, really important to know what the pupil's doing, particularly pre-intubation, because once you've got drugs on board, that may cloud the assessment. If you have a unilateral fixed and dilated pupil, it's potentially still salvageable. Bilateral fixed and dilated pupils, much less likely to be salvageable. And someone who's had bilateral fixed and dilated pupils for a long period of time, and by that I mean several hours, their likelihood of ever recovering is very small, and that's likely to sway the decision on whether or not they have an operation. Coagulopathy, and I include medications in that, has a big impact. We know that those with either coagulopathy from, say, liver failure or because they're on an anticoagulant are likely to have a worse outcome. Bleeding is difficult to control. And also, what are their other injuries? If they're polytrauma and they've got multiple other injuries that are likely to have an impact on their ability to recover from a brain injury, then that needs also to be taken into consideration. So if you go down to resus, you can always tell when there's a DCS in progress because there's a lot of activity. Things are moving very quickly. When there's blood on the floor or there's no blood pressure, people get very excited. It's different with neurosurgery because often patients are nicely packaged by a very calm anaesthetist. Everything all looks very under control. Everything's moving at a slow but steady pace. But we just need to bear in mind that there is a time critical aspect to it. But when we haven't got the visual cues to that, we sometimes forget that. So when do we operate? Some of you might think that neurosurgical registrars want to be operating all night, and I suspect some of them do. But we all know that the night time is not the best time to be operating. But sometimes we need to. And which patients should we be operating at night? Well, these are the sort of things that we might do: an external ventricular drain for subarachnoid hemorrhage or acute hydrocephalus. Occasionally a shunt revision, but not that frequently. Most patients with shunt malfunction can wait till the morning, and it's always better to do it in daytime hours when you've got appropriate people around. We might have to do a craniotomy for an acute subdural or an cerebral hemorrhage. We might need to do a decompressive craniectomy for a malignant MCA infarct. These are all time critical problems. Burr holes for chronic subdurals, these often get shifted into the nighttime or the early evening, and that is partly a nature of capacity issues. Ideally, these patients should be done first on the list in the morning, but often due to capacity problems, then they're not. They do get left. And likewise, it's not always appropriate to do them in the middle of the night, but some of them do need doing, and there might be some reasons why they need doing overnight. Cerebral abscess, sometimes we need to do this early on to get a diagnosis, particularly if there's a risk of rupture to the ventricle, but it will be on a case-by-case basis whether something can wait till the morning or not. And occasionally spinal decompression discectomy for a quarter of Weiner syndrome. Okay, so what are the reasons for deciding whether or not a patient needs to go to theatre out of hours? Well, particularly if their motor score is less than 6, that might be a reasonably good indication, or if they've got significant midline shift with a reducing GCS or a hemiparesis. So the classic one is the chronic subdural who's had a chronic subdural for perhaps a week. They've been sat in their district general hospital. They come over 5, 6 o'clock in the evening. By the time everything's set up, everything's other cases going on, it's 11 o'clock midnight before you're ready to go to theatre, and the question is, does this patient really need to go to theatre tonight? If they've just got headaches or a bit of drift, a little bit of confusion, probably not. But if they've got a hemiparesis, they're drowsy, they've got a lot of midline shift, then it might well be reasonable to consider doing them overnight. But again, it's on a case by basis, and always discuss with the consultant involved. We might take someone to theatre because they've got medically refractory ICPs, I've talked about abscesses, or if they've got a corner equina syndrome. So this is just an example of one weekend of referrals for intracerebral hemorrhage. And I think out of these 10, maybe one got operated on. So what's the decision making behind when we operate on ICH? So first you need to consider what the benefit of surgery is. We can reduce the ICP, we can reduce the mass effect, we can prevent other problems like brain herniation. We could perhaps reduce the effects of the secondary neuroinflammatory cascade, try and control any source of bleeding and prevent further hemorrhage. However, which is what I always remind our registrars, removing a clot is inherently destructive. You're always going to sacrifice some functioning brain and some potentially salvageable brain. So it really is, in my opinion, a last resort. And if a patient can manage without that clot evacuation, then that is often the better option. So the reason to do surgery would be to prevent death or reduce that secondary brain injury, but it does not improve their neurological impairment. And that's what we try and get across to the stroke physicians and families, that removal of clot is really going to prevent worsening rather than improving their initial impairment. There's a number of reasons that make an ICH more favourable for an operation. So, for example, the location of it, if it's lobar rather than deep. So the example here is a deep hemorrhage. But if it's in the frontal lobe and it's superficial, it's more favourable. Or if it's in the cerebellum, certainly more favourable to evacuation. What's its size? Is it causing mass effect? Is it causing hydrocephalus? What's the patient's GCS and neurological deficit? If they're GCS 15 but with a hemiparesis, you're not going to achieve anything by taking that clot out. If they're GCS 12 because of mass effect, then you may well improve things by taking that out. And as I mentioned earlier, what's the age, comorbidities, etc., patients' wishes, what level of disability are they willing to live with? These are life-saving operations, and you're potentially, you're potentially condemning someone to a life of severe disability that they might not have wanted. And so that's why it's important to understand what the patient might have wanted. So what can we do in these particular cases? Well, we sometimes put in an ICP monitor, but usually only if patients intubate agitation and we just want to try and help ICU management. But otherwise, it's craniotomy and evacuation of the hematoma, or we could just do a decompressive craniectomy, take away the bone, relieve some of the mass effect, and leave the clot alone. And you might do that in the cases of where there's an underlying aneurysm that hasn't been secured, and it's the middle of the night and you don't want to risk taking out the clot at that time. If there's hydrocephalus, we can put an external ventricular drain. And I'll just put in brackets there, image guided catheter clot evacuation, which was thought might be a useful treatment that the interventionist radiologists were interested in, but it hasn't really come to fruition. I'll just show a couple of studies later on showing that. So the sort of patients that are going to end up going more down the medical route are those who don't have significant symptoms, or they have a good GCS, or those at the other end who have little chance of a good outcome. And you can use the ICH score to give an idea of what someone's risk of mortality is. If they've got severe coagulopathy or comorbidities, but also the deep location. And we know from trials that surgery is no better than medical treatment in these patients. So the ones more likely to have surgery are those with the mass effect or symptoms related to the raised ICP. Ones with sort of more moderate rather than small or large hematomas, and those that have failed medical management. And certainly the younger patients are more likely to do better as well. So a number of studies have looked at this. You may or may not be familiar with some the Stitch studies. Really showed there was no benefit with early surgery compared to initial medical management, even with the superficial lobar hematomas. And the MISTI-3 trial looked at the image-guided catheter clot evacuation, found no benefit either. So I've got 2 minutes here. So just going to finish with just talk a little bit about, I suppose, what neurosurgeons want from anaesthetists. And it's fairly straightforward. I think there's 4 things. Firstly, a patient doesn't move. Sounds very obvious. But as you saw earlier in that video, when we do an ETV, we're just millimeters away from the basilar artery. So even a slight cough at that point can be catastrophic. Optimization of neurophysiology. Well, this is what you do. And I won't go through that aspect. But neurosurgeons really only know 4 drugs: antibiotics, dex, mannitol, or hypertonic saline, and Keppra. So those are the only things we'll ever ask for, other than asking you the dose of any local anaesthetic we might put in, because we can't work that out ourselves. And then the obvious things, the gentle wake up and management of post-operative nausea and vomiting, which actually with modern anaesthetics isn't really too much of a problem. Thirdly, an awareness of the critical steps. See, those that do neuroanaesthesia regularly are very familiar with all of this, but those that come in and do it very occasionally may be less familiar. And I've talked about most of these, so the positioning is important, pinning and our image guidance registration. Then if we're doing a craniotomy, the key step there is when we open the dura, there is a risk of air embolus. There's also a risk of brain herniation. And that's why it's important that we optimize ICP at that point. So we may well ask for hypertonic saline prior to the craniotomy. There's always bits in the operations that are tricky, and that's when surgeons can become a little bit zoned out and occasionally grumpy. And then when we come to close, we're looking for normal tension, sometimes a Valsalva to check our hemostasis or watertight dural closure. And then the post-op aspects, analgesia, dex, Keppra, etc., and low molecular weight heparin is usually by surgeon preference, but not normally before 24 hours. Okay, so I will leave it there and happy to take any questions.
That's really fantastic. A great run through for those of us that don't spend too much time in neurosurgical theatres. Dan, you had your hand up.
From other hospitals. So obviously anyone that need immediate surgery on the basis of the kind of things that I've talked about. Then there are the other ones that will be transferred for either observation or specialist, neurointensive care, and that is very much on a patient by patient assessment, as in what the likelihood of them deteriorating and needing urgent intervention. Sometimes it's a case of, well, actually we know the local hospitals are just not going to manage, and the classic example is the head injury that gets intubated for agitation or maybe seizures, but actually has a normal scan. We are often quite reluctant to transfer those over because there's nothing that we're going to be doing. But sometimes the local intensive care units aren't happy managing them, and so they get transferred over. So yeah, it's very much on a case by case basis of what we think the likelihood of the patient needing us and the likelihood of the local hospital not being able to manage.
There's a question, what did you mention about assessment of the M score? So perhaps you'd like to talk us through, just for revision purposes,
how you do an M score?
Yeah. So the only way to measure an M score, obviously, the first thing you do is talk to the patient, because if they're awake and able to obey commands, then you've got an M6, haven't you? But if you need to assess response to a painful stimulus, the only sensible way to do it is with supraorbital pressure. So it's firm pressure on supraorbital notch. And the reason for doing that is, firstly, it's really painful. Whereas a trap squeeze is actually not that painful. So you quite easily not inflict enough pain to elicit a response in someone who's obtunded. The second reason is that it's above the clavicle. So if you're doing a trap squeeze and someone does that, are they flexing or are they localizing? Okay. If you're doing supraorbital pressure and they come up there, okay, they're localizing. Whereas if they come to there, they're flexing. So it's a way of being absolutely certain you can tell this from seeing a 4 and a 5. And that's really important because, as I mentioned, a difference in a 4 and a 5 may make a difference between intervening or not.
Great, thank you. Any more questions in the room?
No, thanks for that. I've been here since we did the middle, seen sort of the antivirus. Are you guys averse to doing these and doing 7? Like better.
So I mean, I've been here for 5-6 years and maybe done 2 cases in theatre 7 just because of capacity issues. And I know something acute comes in and that's the only theatre available. So we're not averse to doing in theatre 7 if it needs doing. The issue is normally around staffing and kit, and it's often unfamiliarity with the theatre staff that are slightly reluctant to do things. But yeah, there's certainly no reason why you couldn't do some things in theatre 7 if required. It depends what it is. If you're just putting in an external ventricular drain, then you need very little. And in some places they do them in intensive care units or in emergency departments. And actually, we use a power drill rather than a hand drill for those. But that's all kind of kit that can be got quite easily. Or if you're doing a big craniotomy for an cerebral hemorrhage, then you want a microscope and lots of other kits. So it does vary case by case.
You could say that the medical license fails. Rescue ICP says it doesn't change the problem. Then the end of technical research. Actually doing some.
So I don't think Rescue ICP says that it doesn't have any effect other than make people with higher levels of disability. There certainly is some benefit, but you have to balance that against the risk that you are going to leave some people with more disability than otherwise. And the other studies I mentioned were for cerebral hemorrhage. So the Rescue ICP was for traumatic brain injury and failure of medical management randomization to medical or surgical treatment. And certainly surgical treatment does lead to more survivors and more patients with a good outcome, but equally more patients that would have died otherwise have been left with a severe disability. So that's why it's really hard and choosing the right patients. And I've got patients that have done really well from a bifrontal decompressive craniectomy, where at the time you think, am I condemning this 18-year-old to a lifetime of severe disability? And not always. Some people do really well, but it's about choosing your patients wisely, and that's not always easy.
Cool.
Touched on it a bit. I guess surgery is fairly unique that you're making a decision for emergency surgery without patient. You guys do kind of all patients.
Yeah.
Yeah.
Well, so there's some patients you get referred early on. So I'm thinking the MCA infarcts that might be considered for decompressive craniectomy. And when we do get those referred early on, we do usually ask the local teams to have that conversation with the families and the patient whilst they still can, and that's really helpful when they do. However, I think certainly physicians have a very different view on what the surgical outcome might be. So you then go and have a conversation with the family yourself, and you have a completely different outcome at the end of that conversation. So the sort of things that we do increasingly, I think, is if there's a bit of doubt, we're maybe transferring someone over from Truro for potential decompressive craniectomy. We do sometimes phone the families ourselves rather than relying on kind of the second-hand information from the local teams, just to try and gauge that. But equally, once they arrive, if there's time, then it's always good practice to have that conversation with the family before you go ahead, because it may well change your decision. But sometimes you don't have all that information. You have to make a balance of judgments on risk benefit. As I said, sometimes you don't get the outcome that you want.
People at home can't hear the questions, so I'm going to see if I can make this work. Any more questions in the room? There's a question from Paul Moore at home. So as our patient population gets more elderly and frail with increasing comorbidities, procedures under local anaesthetic like burr holes, if burr hole evacuation of subdural work well, is there an appetite to develop this further?
For me personally, no. I've only ever done a handful of burr holes under local anaesthetic, and they're all horrible. So, in the sort of patients that we end up doing them on are the ones that are frail, confused, and they don't tolerate it well at all. It's not a nice procedure to have under local. Really, if you're going to have it under local, you need to be cooperative, and not confused, and most of those patients can tolerate a general anaesthetic. So for me, I don't see any benefit in doing them under local, and I actively avoid it. But some of my colleagues do occasionally say, "Oh, do it under local," but then they're not often in the